Okay, perfect. Hi, everyone. Good day, good morning, afternoon, evening, whatever time you're listening to this podcast. My name is Ezinne Asor, and today on the HSB podcast system series, I have a very, very fantastic guest. I feel like this topic is one topic that everybody somehow has talked about. Everybody's interested in health financing because finance seems to be like a very important topic in accessing healthcare and also delivery of healthcare and how government systems actually make sure that healthcare is available for patients globally. And I have no other person than Dr. Abayomi. Just a little big segue. I've known Dr. Abayomi for a long time now. I think just watching him, his articles, his thought leadership in terms of the topic of health financing, I've always noted him that okay, this person is good in health financing. So and I was like, okay, when the topic came, I was like, okay, there was no other person I could think of than Dr. Baimi, and I'm so thankful to him for the privilege to learn from him today on this very important topic that affects healthcare. So I'll just hand off to Dr. Bayomi to just quickly introduce himself to us, and then we get started. Yeah.
Thank you, Ezinne. It's a pleasure to be on your podcast, and I also admire the work that you have done and are doing currently. So my name is Yomi Sule, trained as a medical doctor. I also have an MBA, worked in healthcare finance, management, and technology for more than 2 decades now. Yeah, I've worked mostly on public and private health insurance schemes. I've also worked on providing technology to power the benefits that these schemes provide. And I currently lead a firm that provides credit financing to healthcare SMEs, notably medicine sellers, pharmacies, and clinics, so they can buy more medicines, also keep their services running, buy medical assets as well, and solar assets, and be able to serve more patients, save more lives, as we like to say, and also make some more money as well. So that's what I have done. I'm very passionate about making sure that individuals have access to the healthcare they need, regardless of their financial status. I'm also passionate about making sure that providers are able to provide care regardless of their financial circumstances as well.
That's amazing. I mean, you've said it all. Like someone just by introducing yourself, you've made us know that you have dedicated your life. This is something you're very passionate about. But I mean, just a segue to the question, Dr. Ibrahim, why did you choose to focus on health financing? Like, I know that's a very, I would like to know your why because I feel like reading your bio, I've seen that all your career has sort of focused on that. Yeah.
Yeah. So getting out of medical school, I think my final year, 2002 or thereabout, I was head uh, of the final year conference committee, and the National Health Insurance Scheme was becoming topical back then. Chief Obasanjo was president he was in the process of launching National Health Insurance Scheme, or relaunching it. It was initially launched in 1999, but in 2005 it went live again. Within that time span, it was something that was very topical, and I was very interested in it. And it turned out to be a topic that the conference committee selected. And I also figured that at some point in my career, maybe after residency, I would come into healthcare financing. But a friend of mine challenged me to say, hey, if that's what you want to do, why do you want to spend your life going around in circles? Why don't you just go for it? So by design and probably by chance as well, I got into a health maintenance organization around about 2006, where I had a chance to work on public and social health insurance schemes. So that provided sort of like background and basis for a lot of what I have done since.
That's a very interesting story. So because of a gap and a change in the system, you plugged yourself in to see how you can support healthcare insurance, and you've been doing this for close to 19 years. This is amazing. Thank you so much for sharing that story. I mean, Dr. Bayomi, just going to the foundation of what health financing and why it matters, right? Why do you think that health financing matters? I'm sure everybody knows health financing matter, but your perspective and just looking through the course of your career, right from when you started in 2006 till now, how would you say that health financing has evolved and why does it matter for countries, and leaders globally?
So first of all, what is healthcare financing? I think it's important to define that. A lot of people focus on the purchasing aspect of healthcare financing, But before you start purchasing, you have to be able to raise the revenues, you have to pool the revenues, and then spend the money to ensure that your population health goals and objectives are achieved. So that's really what healthcare financing is. So if you look at it from that perspective, it's important to people at the policy or country level to make sure that they have funding to drive their population health objectives, and they are not overly reliant on donors or other or out of pocket spending, which, as we know, is not equitable to the average individual as well. Yeah, it's important to them because without an equitable healthcare financing system in place, they would be at the mercy of their pockets or at the mercy of provider reimbursements or tariffs. So essentially, it helps to make sure that people can access the healthcare they need, regardless of their financial circumstances. It's also important to providers as well. So I know a lot of providers, I mean, given that they get better paid relatively on that cash or out of pocket schemes, but it's also true that they end up not being able to see, or they're only restricted to seeing those who have more ability to pay. But if we had universal healthcare financing initiatives countrywide, perhaps continent-wide as well, it will mean that everybody will be able to access healthcare, and finance will not be a barrier. It will mean that the providers also can model or anticipate or even project and budget more effectively. It will mean that they're able to serve more people, save more lives, and make more money essentially as well. So it's important to the policy makers, important to the individual. It's also important to the providers as well, and also investors as well. If you're an investor, you want to look at your returns. Right now, the revenues are not predictable. I mean, if you had a community of 1,000 people or 10,000 and 100,000 people who you knew that finance was not the barrier, it's definitely easier than for you to start focusing on a subset of that, of those who have ability to pay. And as we know, incomes also fluctuate. So if you're in a community where it's the predominant occupation is seasonal, people might only have money when it's harvest time. Even if you're in a community of formal sector individual, what if there's a recession, as we saw in time past around 2008, and several times since then, where lots of Nigerians lost their jobs and also lost their private health insurance schemes assets as well. So equitable healthcare financing is very important to everyone in the society.
Thank you so much for sharing. Obviously, like everybody knows health finance is very important. And, you know, imagine somebody having to spend 80% of their income just to treat a condition. I think that is not sustainable for anyone and any country as its whole. And a couple of days ago, I was just chatting with a friend of mine who is like doing VC, and she was just sharing with me like, why is it that, there's never been an exit in terms of like healthcare startups compared to like other startups in low middle income country, like investor, like just buttressing on the point you made about investor wise, and how it's very hard for healthcare financing to get their return on investment, right, for their investment in healthcare. And I'm just curious to know, like, what are those misunderstandings that we need to know about health financing across the public and private sector? And I'm sure they differ because the way governments will look at, healthcare finance is different from the way an investor. So for example, somebody who's looking to invest in healthcare in Africa, let's use Africa as an example. Like, how do you think that differ, like in terms of how they approach, the investment in healthcare? So yeah.
Yeah, so like I said, a lot of people focus on just the purchasing aspect and they think healthcare financing about how providers are paid, but it's much more than that. You have to think about how the revenues are raised. Is it going to be tax based? Is it going to be universal? Is it going to be mandatory? Is it going to be voluntary? Is it going to be contributory? How do you pull the money, the funds that you have raised? Is it going to be in one big universal pot or pool, or is it going to be multiple fragmented pools? And finally, what sort of purchasing instruments do you deploy to be able to achieve your population health objectives? It's very important to have those objectives because healthcare financing is not an end in itself; it's a means to an end. And at the end of the day, you should have your targets. Do you want to reduce maternal mortality? Do you want to reduce or you want to increase life expectancy? What exactly are your population health objectives? So for me, it's very critical that people understand that healthcare financing is not an end in itself; it's a means to an end. And so you have to be clear about the end. You have to be clear also about how you're going to raise revenues. You also have to consider consider the society where you live in. So, I mean, I always say it somewhat that everything we've done and everything we are doing is a social experiment, and we should take feedback from it. If it's not working, we should pivot. Even from a policy perspective, pivots are not just health tech or technology driven initiatives, even within the public sector policy space. If you have been doing something for 20 years and it's not working, you have to ask yourself, what else can you do? And you want to change, you want to look at what else you can do as well. And so I think it's important to look at it from that way. So within the public sector, I mean, we've tried. People have felt that, oh, if all they needed to do was to pass a law saying health insurance was mandatory, everybody would comply. But it's not so. Health insurance is cultural, it's social-cultural. There's social-cultural drivers, around the decisions that people make to procuring insurance and even health insurance. So unless you design initiatives are the initiatives that kind of key into the natural health seeking behavior and health buying behavior, I'll say you're not likely to get any traction. Another big misunderstanding is thinking that if you pass a law, everyone is going to comply. The other big misunderstanding I've talked about is people thinking that healthcare financing is just about provider payments. It's much more than that. And like I also mentioned, people also think of healthcare financing in isolation. They don't look at it as a tool, which it is. It's not an end in itself. It's a means to an end. Your end also should always be making sure that people are financially protected, that everybody can access the healthcare they need, regardless of their financial circumstances. You talked about someone who will spend 80% of their income. The vast majority of people will not even be able to access healthcare if there were no universal health financing initiatives as well. For the private sector as well, there's a misunderstanding that social healthcare financing initiatives are inferior to out-of-pocket payments, and so they continue to double down on making sure they get cash paying clients in. But like I mentioned, it's a case of, do you want to serve one or two people who you're not sure whether they're going to come, who will pay you a lot of money, some sort of surge pricing initiative, or you want to be able to serve everyone in your community, where funding is not a barrier. I would argue that it's more sustainable to be able to know that you are in a population of 100,000 people who can pay for your services, than to be in a population of 100,000 people and you don't know the 100 people who can afford your services. And so one, customer acquisition is easier when you know everybody can pay. You can also manage their health better as well, and make sure that they get the sort of outcomes they deserve and you desire as well. Yeah.
Wow. Thank you so much. I really appreciate that perspective of, investors have to get their returns, right? And how it's very important that, we achieve universal health coverage, because I can imagine a cancer patient or somebody who has cancer who does not even have the source of income. How do they even care for themselves, right? It's a very costly condition to manage. And, without universal health coverage or some form of social protection scheme for, healthcare, kind of makes it very hard for those kind of patients to access care. So I think what you've mentioned is very important, that beyond just health financing, it's just an instrument. There are other pillars that needs to be fixed to even make sure that it works. So definitely we know that, most of the people just say finance is the biggest barrier, but I don't think finance is the biggest barrier. I feel like it is one of the barriers, but definitely works hand in hand with other systems that exist to make sure that, patients are able to access care. Thank you for sharing that perspective. And just move on to the next question in terms of, like, the gaps from low middle income countries, right? I'm sure that we have, I mean, take for example, I've had a number of people on the podcast from different countries. Tanzania, when he came, he was quoting some of the quotes of, the gaps in health financing. Namibia, when he came on the podcast, they were one of the guests who was a market leader in Namibia, was also quoting the gap. But I feel like Namibia is even doing better than, some countries like Nigeria and Ghana. So I'm just curious, like, in your perspective, what would you say are the gaps in financing healthcare in low middle income countries, and those choke points and the models that we need to revamp?
Yeah. So first of all, we're not making enough money, even as a country, or most of these LMI countries don't make enough. Take the case of Nigeria, for instance. The average productivity is quite low in Nigeria. So that means that government's collection or revenue to GDP is low. In fact, in Nigeria, it's probably the lowest in the world. And you can only give what you have. So if government is not raising enough money, government cannot pull enough money together. Or if government is not collecting enough money, can't pull enough money together to be able to dedicate to healthcare. So for me, is to be aware of that and make sure we support initiatives like the new tax reforms in Nigeria and other LMIC countries. And so I'm very much in favor for that. I personally don't believe in contributed health insurance schemes, especially populations that have large informal societies like Nigeria and other LMICs as well. So for me, rather than trying to make sure you're fixing taxation and then you're fixing getting people to pay for health insurance, you want to collect for them for health insurance, you want to collect for them to tax. I'm always in favor of fixing taxation. Just get everybody to pay something, and once they pay something to the pool as tax, give them some medical benefits. The medical benefits ideally should be universal. There should be no discrimination between what those in the public sector and private sector have. Of course, those in the private sector or those who have may decide they want top-ups, but you want to create a minimum floor, a basic medical benefits that everyone who is part of your society can enjoy because they pay their taxes. So fix taxation, generate more, have one universal pool. Even if for political reasons you have multiple pools, you can create virtual pools that are administered as one, so to speak. Multiple pools are inefficient. They're inefficient in the sense that imagine if we had a pool of 100 million Nigerians, 200 million Nigerians. It means we can bargain with providers for better rates. We can plan more. We can bargain with manufacturers of medicine. Say, hey, we have 100 million or 200 million Nigerians. This is the sort of requirements they will need, or care they will need over the next 1 year. Can you produce commodities for this population? So that's why I'm in favor of one pool. It's also easier. Pools will have multiple CEOs as well. We'll have multiple employees doing the same thing. In these days of technology, you can have technology driving a lot of the data crunching and decision making. And so maybe you might even need the same number of workers, but of course you will not need a lot of executives. But imagine you had multiple pools, you're going to have a lot of executives, and that will lead to a more administrative spend as well. And so one thing is collect more, collect better, pool centrally, and also purchase strategically as well. A lot of purchasing is not well true. They are not tied to population health objectives. So I mean, while I know that cancer is a big issue, a lot of Nigerians, a lot more Nigerians die because they're trying to give birth or when they're trying to give birth than because of cancer. And so we can very easily use healthcare financing strategic positions to make sure that everyone that we can contract with whether public and private healthcare facilities to be able to provide care to these women when they need to deliver. That financing is not a barrier for them. So again, purchasing should not be passive, it should be strategic as well. You might also want to do reward-based purchasing as well. Everybody gets a minimum, but if you have better outcomes, you get the provider gets a bonus.
Thank you so much.
So
I
for me,
think
those are the three big issues which we need to fix: collect better, pool better as well, and also purchase better as well.
Thank you. I'm just taking notes of what some of the things you've mentioned. Actually, what you've said is really true in terms of like not making enough, like the government not making enough to finance the system, right? I think a lot of low middle income countries do not have efficient government generating revenue systems like tax collection system. And I'm really somehow happy about what is happening in Nigeria. Not 100% happy because we know the state of the economy, but definitely we hope that the revenue generated will translate into something meaningful because definitely yes. But I mean, also just comparing what is happening in developed nations like the US and some other nations like Europe and UK and all these nations that already have tax system in place. I don't know if it truly translated into like better care for patients or for the citizens because despite the fact that they have government backed insurance schemes, it's not like it's 100% efficient, right? So I'm just also curious, if we collect more, is it guaranteed that, the low middle income countries have the capacity to make sure that patients or the insurance schemes get to people who need them and they also get the care? That's another debate, but definitely I love your three.
Absolutely, absolutely, absolutely. And I've always been clear. Healthcare financing is not the silver bullet. Getting everybody insured is not the silver, or covered as we like to call it, is not the silver bullet. Again, it's down to how do you do it? What are the mechanisms to deploy? What sort of providers you contract with? What are the sort of objectives you're also trying to achieve as well? So, I mean, healthcare financing comes in different variants. It could be insurance, it could just be strategic purchasing instruments you are deploying, but it has to be well thought through. It's never been a silver bullet, and it will never be. Again, even raising more revenues itself is not a silver bullet. You also have to look at efficiency and making sure that there are no leakages. But I also know that if you don't raise enough revenues, you're never going to get anything done. So you know what I mean. So do you want to keep
Yeah,
saying
yeah.
that, oh, the situation is not good, but we don't fix taxes because we don't know what will
Mm-hmm.
happen when we collect more?
Yeah.
Certainly, it's not going to improve if you don't have enough money. So let's
Mm-hmm.
fix that.
Yeah.
Then we can focus on
Absolutely.
efficiency and accountability
Yeah.
as well. We can
Mm-hmm.
focus on making sure that the right instruments are deployed such that the funding or financing is achieves the objectives that's required to be achieved as well.
Thank you so much for sharing that. I think that's very, very important that it's not a silver bullet, but it's definitely a step in the ground to make sure that, we have at least
Absolutely,
something that we move
absolutely.
forward from it. And efficiency and accountability is very, very important in that regard. I mean, just based on what you just said now, like, so can we say it's possible to have a sustainable, healthcare, or is it possible to say there is sustainability because of we have better financing structure that we have in place, or is it far-fetched?
No, it's definitely possible. And I mean, it's important that the schemes are structured in a manner that the financing flows are predictable. Again, that's one reason we keep saying not in favor of contributed health insurance schemes, especially in societies with large informal populations. So if you're able to collect 50 naira, I mean, people have argued that perhaps the issue is that we need to break down the premiums that are required for this informal sector to daily contributions or weekly contributions. But the challenge is that even if you use technology, you are not sure you are going to be able to collect from them because their incomes are very erratic. It's not the incomes are not predictable. But imagine if you're collecting on a countrywide or statewide basis and it's going through a central pool. Of course, the state has the ability to be able to modulate how much money that comes into that central pool. If they need, they will raise debt to ensure that the healthcare sector is well financed, or maybe not just healthcare sector alone, on an ongoing basis. And if you look at the budget of any state or country, there is always a fraction of their revenues that is debt. Yeah, so even when collections are not possible, the government will always have money. So financing from social health insurance schemes, especially when their tax base are more predictable than contributing health insurance schemes. And of course, out of pocket is the most ineffective and most erratic that cannot be predicted from the macro or even the micro basis as well. So you want to look at the predictability. You want to look at also pooling. Also pooling gives the entity that is making doing the pooling the bargaining power to be able to purchase effectively or efficiently for the citizens or members of that pool. The members could be on the private level, the enrollees of a health insurance scheme. On the social level, it could be citizens within a state or a country, as the case may be. As you know, individual incomes also are vulnerable to shocks. So if you're depending on individual incomes for out-of-pocket payment, that is the most vulnerable, so to speak. But if it's tax based, yes, there might be macro health headwinds, but I believe that collectively, states or countries are better able to weather macro storms than individual families. Individual families are vulnerable. And that's why, even right now, a lot of people within low middle income countries cannot access the healthcare they need. For the basic, I wouldn't say the basic healthcare they need. Mater mortality is still high, under five mortality is still high. Life expectancy is not where it could be because of these reasons. It's not because people are dying earlier. It's just because a lot of babies are actually dying. And so if we fix that using the right financing instruments and incentives as well, people respond to incentives. And if we fix that, I think we're on the path to sustainable healthcare financing schemes.
Wow, thank you so much for sharing that. I think you've mentioned a couple of times in this conversation the place of maternal health and, just starting from children. I'm just curious, maybe even as a child is born, if their parents are able to give them some form of social protection scheme based on the tax bill. I don't know what the government is planning, but I think that would be a fantastic way to ensure that we are able to sustain the life expectancy of children that come into, low middle income countries. You also did mention something about the private sector that I find very, because I did work for a couple of years in private sector, and I'm just
Mm.
taking Nigeria for an example, right? The divide between the private and the public sector in terms of like the accessing out of pocket spending, it's outrageous. Like more than 70% of patients go out of pocket to purchase And I'm just curious, why did that happen? Is it because we never had any? Yes, obviously, maybe for one, we didn't have any sort of insurance scheme for the informal sector. But is it something? How do because we have this so big a large divide? How can private sector investors fit in, like private capital and like private investor? How is it possible that they come in to support in some sort of way? I know we have a lot of private health insurance companies and stuff like that, but none of them really, most of them are employer based, private sector health insurance schemes, and mostly do not cover the informal sector. So I'm just curious to know, like, your thoughts on how private sector capital can fit in this topic.
That's a good question, but haven't said so. I've realized after working in this space for the last 2 decades or so, first of all, social health insurance schemes are the way to go. And if that's so, then the private sector's role is to figure out how to make money and pay their taxes to government. Of course, they can demand accountability. Of course, private sector also can invest in healthcare facilities that take in enrollees from the social health insurance schemes. The challenge is that you might have health insurance schemes, but if the reimbursements are too low, effectively it means that while you're not saying you don't want private health facilities, reimbursements are too low, the private health facilities will not be part of such schemes, and we have that in Nigeria and several other countries as well. So yes, you can flip it around and say perhaps the private sector should invest in low cost some healthcare facilities that are able to match those premiums. That could be, of course, one way to those reimbursements that the social health insurance schemes are offering. That could be one way to go, so to speak. Another way certainly is to say that the private sector can also demand accountability from government and say, okay, so we're giving you all this money. Who, how many people are you treating? Which providers are receiving funding from you? For so many social health insurance schemes, that level of accountability, I don't see it being demonstrated. Who's receiving the funding? What are they being treated for? What I mean, essentially, where is the money going? Of course, it could be as granular as possible without compromising privacy requirements. Of course, the private sector can also innovate if they know where the money is going. For instance, there's a lot of funding going into malaria. Perhaps they will be motivated also to innovate accordingly and provide the latest malaria treatment regimens, so to speak. So, I mean, I deliberately avoid saying that the private sector needs to see itself providing private health insurance. I really don't think so, because most of the private health insurance scheme we have seen across most part of Africa or low middle income countries are very small scale. They don't have the capacity to be able to effectively acquire and pull together millions of people in one big universal pool, so to speak. And that's because of all the reasons that I mentioned. The people in the formal sector are not that many. So if that's the case, so I would say the private health insurance or private health sector should look at ways it can complement what government is doing, and ways it can really help government to succeed, hold government accountable as well, and also figure out ways to deliver affordable care at the best pricing. So I would not say the least pricing. I think if we talk about the least pricing, it's a race to the bottom, which might not be in the interest of the society on the long run. But optimal pricing, so to speak, optimal cost base and optimal pricing as well.
Thank you so much. I just recall the conversation I had with one of the market leader in Namibia in patient care, and he's working on health insurance scheme for private sector. Maybe we can learn some one or two from how he's doing that in Namibia, because they've been able to like help the informal sector upscale through their startup, right, to have some sort of insurance scheme for basic care, right? And I think there's an opportunity for any investor or anyone who's looking to support this field. It just takes a lot of thinking and a lot of strategy in this regards.
Basically, I started my career providing offering community health insurance schemes. That's probably one of the launch parts of my career. So I know a lot about providing care to low income communities, probably than many people. I know you cannot do it on a sustainable basis, a sustainable commercial basis, without doing it as a complement to to government provisioning, so to speak, either from a financing or from an infrastructure or service delivery perspective. Yes, there will always be a role to have pilots, but we're talking of we want to see schemes that are covering 10 million people, 20 million, 50 million,
Yeah.
100 million people. That's success for me. I'm not saying that there is no space if you want to run a scheme that is covering 100,000, 200,000, 500,000. It's still possible, but I'm not sure that's success based on the way I see it. I think the greater success will be partnering with government. So one way, of course, is like I said, government defines what a basic package is. Government funds that basic package because people are contributing. Private sector is contributing to that pool, and people who want top ups can provide can take top ups from the private sector. The top ups could be for dental. Top ups could be for fancy things like treatment in Dubai or India. Yeah, so there will always be a case for the private sector, room for the private sector. But I think in terms of, if we're talking about universal mass coverage, I think that's a social good. I think that's a public good. And I'm not quite sure that the unit economics end up working out
Mm,
for those who want to do it as solely private sector, as a sole private sector driven initiative. That's not to say it's
mm-hmm.
not doable. You can do it.
Mm-hmm.
Probably have coverage for 100,000 people. The scheme that I ran had, I think I had to speak about 100,000 people or more, maybe 120, 150,000 people in Kwara and in Lagos. So yeah, and that was like 15 years ago. So I do
Oh
know
my
quite a
God.
lot about, and these were all low income people
Wow.
who were benefiting from subsidies provided by generous donors. But yeah, but that's not sustainable. Those schemes now are dead. They no
Mm-hmm.
longer exist. Uh,
Yeah.
Not just because we have the government schemes, it's just
Mm-hmm.
because
Mm-hmm.
the donors cannot continue to fund such schemes
Absolutely.
forever.
Mm-hmm.
And that's why I'm passionately in favor of
Mm-hmm.
tax-based financing. If you look at what's happening right now, governments
Yeah.
in Nigeria are making more money, but a lot of that funding is not going into healthcare. It's
Yeah.
going into airports that are going to have maybe 5 planes a day. It's going into roads that are going to have
Yeah.
few cars drive on them. Yeah, so we need to get government to put
Exactly.
more into healthcare. I think that's the most sustainable way. Of course, the private
Absolutely.
sector has a role. The private sector can build facilities, and she'll build facilities. But we need to hold government accountable because they're
Accounting.
stewards of the system. They're stewards of the financing we provide as well. I think from a systems perspective, that's probably the way to go.
Mm.
Again, I say probably because we still need to have these workouts and we still need to
Yeah.
make sure that all the conditions that are required for success are there as well. But we have seen that private sector alone can't do it.
Cannot do
Private sector
it.
has a profit imperative. Can't If you have a profit imperative, you are going to cherry pick where you choose to pilot. You're not going to go to places where women don't have money, or where all they have is a tuber of yam
Okay.
a month or something like that. You will cherry pick where you can make the most money, so to speak. But if you have if
Wow.
you have if you have the public sector, which is not profit driven,
Mm-hmm.
which should be goal driven
Yeah.
and oriented as the one who provides a minimum ceiling or a minimum package of benefits, so to speak, that guarantee access to primary healthcare services. I think that's probably the way to go. Um,
Oh my God. I feel like Dr. Obayomi has already nailed this. Experience is speaking here. So if you're looking to do anything in health financing, you should reach out to Dr. Abayomi because he does have the experience and he's not just talking theory. He has done the work and he has understood what works in low middle income countries. So all who is watching, I think you should. I mean, if you're thinking about doing anything in the health financing space, it's always great to get, experience from the market to guide you and share knowledge and, support you in any way. And like you said, you can't do this alone. And I think that's one of the reasons why we had a podcast series about partnerships, right? Because most times people come in and say, I want to change. Why is something not working in healthcare? I want to do this. I want to launch a startup. I want to do an AI solution. But you realize that you can't do this alone as a private sector. You need the public. They need to be this public private sector partnership. They need to be this PPP partnership to launch anything in healthcare. Healthcare is not just a silo that, oh, I just want to have people to access care. There are regulations, there are policy, there are systemic barriers, there are things, there are social behavioral changes you need to make. to make sure that patients actually have the care that they need. So definitely, like you said, private sector has a part to play, but you can't do it alone. You need to work and possibly plug in with existing public sector structures like the health insurance schemes that Nigeria is trying to put and launch, revamp in 2026. So I'm keeping my eye in that space because I'm looking forward to what Nigeria does in that space. But thank you so much, Dr. Abayomi, for just speaking. That experience really matters. So we'll go to the next question in terms of like innovation in health financing, right? I know you've worked, and I think you already said it. You've worked community based, you've worked technology, you've done a lot in this space. So, but what are those new and emerging, models globally that we are seeing? I know you've talked about a couple of them, like pay for performance and stuff like that, tax based and all. What else? What is that new and emerging, model that you think that countries and healthcare leaders should begin considering, right, in terms of like health financing?
Yeah, I think the first model, like I said, we don't have a lot of it happening in this part of the world. Though I would consider the Ghana National Health Insurance Scheme to be tax driven. It's not exactly because a lot of the financing comes from their VAT as opposed to Nigeria, where most of it is still contributory. So I'm definitely, and I can't say this enough, it will seem like I'm a broken record. It's tax, tax, tax. Not don't expect don't. I mean, I'm not in favor of. I mean, I've seen it doesn't work as effectively as we want it to work. The contribute health insurance schemes. And contribute just means that people are earning a living and they are paying for their premiums themselves. But like I said, why not get people to pay more for tax? So any innovation in a sense that helps government to collect better from people, for me, it's a healthcare financing innovation.
Mm-hmm.
People might see a payments company as being very far removed from healthcare financing reform. But I would see very much say that a payments company that helps government to collect better, and if government decides to use those revenues, pool them centrally for healthcare, that is a healthcare financing innovation. We also see innovations around service delivery using telemedicine. The jury is still out on the effectiveness of that. The cultural imperative is people want to go and see a doctor before a doctor or a pharmacist or even a medicine seller and be spoken to, and they don't usually want to speak through a screen at a doctor or healthcare provider on the other hand. I'm not saying you don't have an opportunity for that, but I don't think we've seen traction yet. The jury is still out on whether that's going to scale effectively as well. I mean, in between all this, we have people who are experimenting with wallets, again, typically around contribute health insurance schemes where everybody can contribute into their wallet or into a wallet, and maybe the government adds to that wallet and they can use that wallet to access benefits as well. That wallet also can store their health data as well so that they can take it from one provider to the next. That wallet can administer their benefits intelligently as well so that the providers know what benefits they are eligible for and how much co-payments, if any, they need to pay as well. Yeah, so in my mind, those are the sort of innovations that are out there. But to be honest, there is so much innovation that is possible and doable if we expand our thinking of healthcare finance beyond just paying providers. If you look at it from the fact that you can help government to generate more revenues, you can help government to pool better. And even these days that we have AI, if you have an AI LLM that can help public or social health insurance or private health insurance do their jobs better, or even providers do their jobs better as well. For me, I would see it as part of the innovations that are possible as well. Intelligent EMRs, yeah, that have built-in benefits management so that people spend less filling forms to send to health insurance or to the public health insurer. I think, yeah, those are innovation opportunities as well. I mean, if any innovation that is possible within the healthcare space, for me, you could see it as part of the healthcare reform because I think one way to look at it is how can I make sure that people are getting more value or more health for every naira or dollar or shilling that they're spending, as opposed to. So I think it's two things. There are two innovation opportunities. How can we bring more money into the healthcare space? How can we get more shillings, more naira into the healthcare space? Two is how can we get more value for that funding that comes in? Those potentially be a wide area of innovation that is possible or doable.
Thank you for that perspective. I think it's really important to learn that, different part of the world are in different area in terms of adoption of innovations. Like you talked about telemedicine. I think it's very important, here at Johns Hopkins, where because the first telemedicine that was launched in for COVID-19 came from Johns Hopkins University, and I was in a meeting and they were showing a graph of the adoption of telemedicine since COVID-19. The first telemedicine platform was launched at Johns Hopkins, and I was so impressed that there was a spike, and then after a while there was a decline, and there is still a decline in the adoption
Absolutely.
of AI. So I'm not, I'm not,
Absolutely.
I'm not like, okay, if it's in Johns Hopkins and in the US, how much more low middle income countries? So I think you've raised a very valid point that maybe at some point, because of now that AI and technology is now being pushed by, Silicon Valley investors to be one of the biggest, maybe there'll be a change or a shift in behavior in the next 5 years. Perhaps that can even drive adoption for these financing models we've talked about, the wallets. I like the idea of the wallets because it makes it seamless, right? You pay, but I don't know how adoption, nobody knows, And I think we're all learning through it that, it differs across different clients. But thank you for raising that perspective. And also the value for money you talked about. I don't know how that will work you know, in a emerging market because, it's already very cheap to access care compared to like developed nations like the US, where care is very, very expensive. So I know that it will take a lot of, distilling of that concept to make it work in emerging market. But I really,
There's still a lot of inefficiencies
mm,
here as well. So yes, while relatively, if you earn dollars or you earn
yeah,
euros, you will see anything priced in shilling or naira has been very cheap. But the truth of the matter is that within that current prices are still some inefficiencies, some costs that are unnecessary. And then if you just oppose that with the fact that the people who need to access the care don't earn in dollars, they earn in naira, and the government itself does not
yeah,
collect, mostly collects in local currency as well. It means that you can still squeeze out a lot of inefficiencies. I mean, there are estimates of the fact that even within current healthcare financing or healthcare spend, you can have inefficiencies as much as 30 to 40%. And these inefficiencies can be for a lot of reasons. It could be because people are not coming to work when they should be. It could be because we're not buying in bulk. We're buying in batches, and so there's still a lot of
yeah,
opportunities for innovation around efficiency as well, both from the public and also the private sector
yeah,
perspective as well. I'm
yeah.
not in favor of bare bone initiatives. Don't get me wrong, but I'm
Mhm.
simply saying because when it's bare bone, it's not optimal. But I think we can the current money that is available can be used to cater for more people, so to speak.
Yeah. So that there's this concept of, the buy now, pay later schemes that are happening right now all over the world. And I don't think it's just unique to healthcare. All over different industries now we are seeing that there's been an adoption to
Yeah.
that financing scheme for commodity products. So I'm just curious to get your perspective on that in healthcare. Do you think that is something that is feasible and, in terms of like the behavioral and the psychographic nature of Nigerians and Africans and emerging market. How do you think, what's your perspective on that? And just yeah.
So I'm not just going to give you my perspective. It's something I've been trying to launch for the last 2 years. As you know, I have a healthcare focused lending company, and while our lending is around the business, we also want to make sure that the businesses are not hampered by people who are not able to pay. And then, so if people are not able to pay, we've been thinking of ways to ensure that they can receive care now or heal now and pay later. But you also have to look at within the context. How many people have employment? How many people use the financial system? How many people have money left in their banks at the end of the month? How mature is the payment system? What's the buyer behavior? What sort of treatment are they looking at? Can you do buy now pay later for emergencies? Not likely. I won't say no, but I've not been able to figure out how to do it. And so what we tried to do was to focus on elective procedures that are not covered by health insurance. But the truth of the matter is that in many instances, you're dealing with sometimes not just with the individual, you're dealing with the provider as well. And I know that for things to scale within that space, the provider has to believe in the product. The provider has to ideally push the product to the patient as a payment alternative, not even as a financing instrument, as a payment alternative. But unless you have providers who are willing to do this, it has to also, like I mentioned, it has to be for the right type of products. You can't, or services. You can't do it for emergency cases. Not likely. You can't. You have to do it for cases also from a risk management perspective. Cases that are staggered. If people get all the care that they need in one go, in this part of the world might find out they don't come back to pay for the service later. But if they know that they have to come back to the for the
Yeah.
doctor for a repeat treatment, and if they don't keep paying, the doctor is not going to cater to them. They will be more likely to keep paying as well. So we're still trying to figure it out, and that's because, like I said, there are multiple variables. I don't think anybody has figured it out yet, because it's a space, it's a product that I'm actively looking at. We have been very successful in my business with asset and working capital financing, but patient financing or buy now, pay later, care now, heal now, pay later is yet to take off because there's so many variables involved. I know a couple of pioneers within Nigeria and South Africa who've tried to launch this as well, but it's incredibly tough because you have to get the provider to
Yeah.
believe in that product. You have to get the provider to be able to put their name behind that product. You have to get the provider to be able to recommend that product as well. Yeah. So ideally, the ideal product will be a product that the provider underwrites.
Mm.
So if the patient does not pay, the provider would, so to speak,
Stop
step in and
paying.
make the payment on behalf of that patient. Yeah, but most providers don't want to do that, and most patients will uh, so in reality, informally, a lot of patients actually receive care and pay later. But that's a provider-patient arrangement. And when you want
Yeah.
to come in as a third party, it's been
Innovator.
very
Yeah.
difficult to be able to translate that to a formal product because there's so many variables involved. And you're not within that community, but the provider is within that community. So ideally, the provider should be able to backstop that or guarantee that
Yeah.
financing, so to speak. But in many instances, providers are focused on providing
Yeah.
care and they do not want to underwrite this new third party risk. They're very willing to underwrite risks that they themselves generate
Mm-hmm.
for patients who are unable to pay them. But if you come in
Yeah.
with a product like this, it's not been easy to get them to adopt it. So for key success factors would be get the provider to adopt it, get the provider to underwrite the risks or co-share, maybe not fully underwrite, co-share some of the risks, push the product because your risk management will depend on the provider's behavior.
Yeah.
Another key success factor is that you have to decide on what services can be
Can fly.
financed this way. Another way, if the provider is not willing to, maybe an employer, the employer might be willing to, especially for those that have health insurance. But again, the jury is still out on who will be able to have the first mass market
Wow.
heal now or care now, pay later product in the low middle income countries market.
Wow, this is experience speaking. Thank you, Dr. Abayomi, for sharing. I think, one would think from outside, thinking that this is something that is very easy to crack, but this is experience speaking that there's a lot of variables, like you said, that goes into making this happen. Every time I go on Twitter and I'm looking at Twitter and you see somebody complaining, my wife was pregnant, she died because the hospital did not give her they did not want to take her because I couldn't pay. And you are like, why? Like, can't the hospital accept them? But one would think that the hospital would be very receptive of a third party coming to, also share in the risk of, that cost. But from your perspective, you're saying here that, it takes a lot for the providers to put their name behind the back and accept a third party. Because, just this week alone, I've watched like two Twitter viral posts, one saying oxygen, the baby died because the hospital did not give oxygen because of 13,000. And I'm like, 13,000 naira. They lie because of 13,000 naira. And you think that an innovation, as somebody who is innovative, you think that, oh, let me just come in and insure. But you've mentioned the barriers there that it's a lot of variables.
Yeah, yeah. And the solution is really back to what I've been saying. Government should be able to guarantee through universal health insurance initiatives that everyone that comes to the hospital that needs oxygen has that oxygen. It's not far-fetched. It's doable. The other thing, and so to speak, is that there's a lot of money already available. If you look at input financing, for instance, so in most instances, governments have budgets for healthcare. And those budgets are for capital projects, maintenance of health facilities, and payment of salaries. Now, I've been having a discussion with some of my friends that maybe the way to go is not to say we look for new money, but to say, hey, this existing budget, how do we structure it in such a way that it's performance driven? So I give you, your health center, what you're going to earn this year is 100 million shillings. So rather than saying this 100 million shillings for paying 200 workers, why don't you say that this 100 million shillings is to cover care for citizens over the course of the year? And so, even though you know at the end of the day, it's going to be used to finance the payment of the salaries of the workers and a couple of other things, in sort of anchoring it, so to speak, in tying it to some variable that has to do with treatment of people, you can then create some sort of virtual product around that mimics universal health coverage. So we're not just giving you money for salaries, but you
Salaries.
accountable for deliverables and maybe outcomes as well. Even though we're giving, I mean, that's what NHS is all about. They
Yeah.
don't give money for the UK's NHS. They don't give money for salaries. They give money
Mm-hmm.
per individual within a borough or whatever it's called, to a trust health facility, and then that health facility can use that funding for whatever they choose. But at the end of the day, they're accountable for making sure that everyone that walks in within that
Yeah.
borough or that council or local government area gets the care they need. So we
Mm-hmm.
focus a lot on just paying salaries without tying it to
Mm.
outcomes. So we need to
Yeah.
start thinking about that. And if we start thinking about that, maybe we have less people or no people dying from lack of oxygen. I'm not quite sure the innovation is to get them to be able to access credit. I think the right innovation is to make sure that whatever money is available covers X number of people.
Mm-hmm.
Again, we can stretch it further and say, oh, aside from what's available from government, okay, anytime you come for treatment, you pay a nominal amount as a co-payment. And so maybe we could see 1,000 people with government's contribution alone. But with co-payments on people, we can stretch that by a factor of
Yeah.
1.1x or 1.5x.
Wow.
I don't know. So we need to look at innovation also from the perspective, okay, what's the current situation and how can we make it better? It doesn't have to be anything radical sometimes.
Yeah.
Although, so to speak, a lot of political will is going to be required to be able to
Absolutely.
get people to understand and buy into outcomes or output-based financing as well.
Yeah. That's really amazing. And in summary, what Dr. Abayomi had just said is that, the public health system must begin to treat healthcare as a business and not just a social scheme, because you need to be accountable. You need to, generate revenue. You need to make sure that you serve X percentage people. And I really love what the Minister of Health in Nigeria has done, like just putting out the red letter. I read it and I was like, this is actually accountability. This is actually saying you are making people, holding people accountable for the amount that you are giving to the healthcare system. So that is a really, really great perspective. I'm very expectant in the next 10 years what is going to happen in this space. But thank you, Dr. Bayomi. And because of time, we're just going to quickly wrap up the conversation. If you were to, just mixing the questions together, if you were to bring about one healthcare reform, I know you probably talked about a lot of things you think you would like to see changed, or what would be that one health reform that can unlock major progress in health financing?
So I've spoken a lot about tax-based
Yeah.
health financing. I think also what I would like to say is probably what's happening in Nigeria right now, where equity is very important. So a lot of times we try to do everything for everybody, but we have finite resources. So why don't we focus on one, two, three issues and get those right? I know this is not high-falutin, but sometimes it's the basics that are so very important. I mean, in the tech space, we call that niching down. I mean, I do a lot of niching myself. If we're trying to run a product, we focus on a niche or a subpopulation and try and get it right for that population before we talk about scaling. So the public health should also look at that as well. Baby children are dying. What sort of reforms can we do for those dying children? And just get that right. It might mean that 80% of the funding you have is dedicated to accomplishing that. But you would actually have accomplished that rather than throwing money at everything and nothing ever works. I mean, I'm not in favor of saying we neglect men as well or adults, but I'm simply saying there's some problems that have lingered forever because we have not focused, we have not looked at things from an equity perspective. If children are dying, which local governments are they dying? If women are dying, where are they dying? And what can we do to fix that? We don't have to go after women across the entire country. The women outside those sort of black areas, so to speak, are probably receiving care from the private sector and they're okay. They're probably able to pay for themselves. But are there populations that are very vulnerable? So can we just focus on them and get things right for them? So it's nothing sexy, but sometimes these non-sexy ideas are really the way to go. And if you're in the private tech space as well, you don't have to develop a product that means everything to everybody. You can just focus on a niche. You can just focus on a subpopulation. If you want to focus on low-income people, it doesn't have to be low-income people across the country. It could be low-income people across just a few counties, local governments. Yeah, it could just be that, and do it very right. And once you do it very right, you have your proof of concept. You can scale it. You can also, I mean, in also doing it very right, you have to sort of focus on also understanding what are the conditions or variables for success, so that you can replicate those when you scale. So for me, niching is a superpower. Niching is an innovation as well, and that's equity. You can say it's equity. So for me, sometimes equity is innovation. We need to design health systems that are equitable. For me, that's nothing innovative, so to speak. But sometimes we forget that. We forget that it's common knowledge, but we don't do that. So doing it perhaps is innovation. Yes, doing it perhaps is what's innovative, and not just talking about it. We have to, for long, we have had women who are vulnerable. We had children who are
Yeah.
vulnerable, who are dying, women who are dying. So why don't we just fix that? Why don't we just focus on fixing those? I'm not saying we neglect everything, but I think we should niche down on those areas, get things right, and then scale up from there.
Wow, that's so simple yet very powerful. I totally agree with you. We are everywhere and
Absolutely.
nowhere. We need to
Yeah, yeah.
focus on a particular problem and let's try to solve it. If it's health finance, let's focus on it and solve it. If it's, malaria, if it's maternal care,
Even
if it's,
healthcare financing healthcare
yeah,
financing is still expansive. It's
mm-hmm,
you can double down on, if you want to double down on, if you look at it from on revenue generation or pulling or purchasing, and if you do that, you want to double down on that on communities that are vulnerable within the population. So we're talking of maybe just a few local governments or a few states within the country, or a few counties or a few boroughs or so. So you can niche down and be as detailed and as granular as possible. Supposed to spreading yourself too thin.
thank you so much. That's very, before we wrap up, the leadership question is very important because I know that, there's been a shift in leadership and a lot of young people who are coming into healthcare, they don't really understand the business. And that's why we're having this. So that just keep ourselves informed, right? In terms of like what the system challenges are and how people have tried to solve, how we are still trying to solve this problem in healthcare. So what would you say young people should understand and current professionals in healthcare should understand? And how do we even build that capacity for health financing? Because I really don't know a lot of programs that provide health financing in low middle income countries, right? So
Yeah, yeah,
how
yeah.
do you build that capacity?
Yeah, so WHO has a program. It's a short
Okay.
course on healthcare financing. It's online, it's free. I can't remember what the exact name of the course, but if you Google HO healthcare financing course, it should pop up. That course has the level one is online, is free. Level two is a 1 week conference, typically in LMIC countries, organized once or twice a year by WHO. You have to get yourself there, but you have to get yourself there. You have to keep yourself to the venue of the training, but the training itself is free. You don't have to pay a cost fee for it. That could be a basis, a foundational knowledge, so to speak. And of course, in many countries, are programs on health policy, healthcare economics as well, or health economics as well. People can look into those for those who want more advanced knowledge. But nothing beats experience. So if you have all this knowledge and you're not doing anything with it, probably not going to be optimal. You need to get busy. You can work with the government or work for the government, or work in the private sector space as well, and put that knowledge to good use. Even in health techs as well, you can advise them. Essentially, yes, is for me it's a model where you have foundational knowledge and then you put that knowledge to use. Thirdly, is you also have to take feedback. So it's not enough to say I'm doing all this. What feedback are you getting? Either from the market or from those people you're serving or those people you're working with as well. You must always figure out ways to get feedback, and whether you like it or not, the market will always give you
Yeah.
feedback. Yeah, and so
The
yeah,
market
so
always
you can
teach you.
course correct on that. Absolutely. Well, I prefer to say feedback and not teach you. Yeah.
Yeah.
So
Thank you so
three
much.
things, like I said: foundational knowledge, experience, expertise, and yeah, and you can see it as a virtual circle. The feedback will help you to continuously refine yourself. It might also help you, might also inform you that you don't know enough. And so every time you continue to consume and upskill yourself as well, and give your services to the market as well. And yeah, continue to take feedback. So you can see that some sort of virtuous circle, so to speak.
It's very exciting. And thank you for the course recommendations. So everyone, please check it out. I think to give you some foundational knowledge on health. But I feel like for Dr. Abayomi, I mean, this podcast itself, I have learned a lot. I have learned a lot from, just understanding the barriers, understanding the challenges of launching health, the models, what has worked and what is not working. So thank you, Dr. Abayomi. This has been a very insightful podcast. I think one of the things I usually end my podcast is with like asking my guests a question about what keeps them grounded. What's that quote that keeps you grounded, right? In terms of like your career. You've been doing this for close to 2 decades now, right? That's a long time. So what is that thing? What is that quote? What is that principle that keeps you grounded? And when you think about, you are always, still very interested in doing something in this space.
Perhaps principle. I mean, there are a couple of principles that I live by. And maybe one that comes to mind is reciprocity. Yeah, the world will always give you what you give to it. So if you throw
Mm.
out a lot of goodness, you'll always get a lot of goodness in return as well. Yeah, maybe I codify it by you would always reap what you sow. Where you reap it, I don't know, but you will always reap it. It doesn't have to be where you are right now. I mean, it doesn't have to be in this time and space. It could be some other time and space as well. So yeah, I live by.
I love that. The world would always give you what you give to it. I think that's very important to keep in, especially in this health financing topic we've talked about. You're giving your best to it, and thank you so much, Dr. Bayomi. This has been very insightful. Healthcare financing, according to Dr. Bayomi, is just an instrument and is not the one size fits all solution to healthcare problems, patient accessing care. So this has been a very insightful session. I think Dr. Bayomi, people can find you on LinkedIn, and he has a lot of experience working in private sector health financing and public sector health financing. So Dr. Bayomi, I guess they can find you online, right? Where can they find your
Yeah,
LinkedIn,
I'm
right?
on LinkedIn. I'm on LinkedIn as Yomi Sule. I'm on Twitter as Yomi Sule professionally.
Him.
Yeah, especially
He's
LinkedIn.
open for collaboration, partnership, advisory, board advisory. I think he's open for this kind of opportunities to just, think and push, move the needle in terms of how we approach health financing, across the globe. So thank you, Dr. Bayomi. This has been a very, very insightful session. Again, the HSB podcast series is the healthcare serious business podcast. And I think we need to understand, like you said, public sector needs to begin to treat healthcare as a business and not just pay salaries and doing stuff. It's actually a business, and we need to deliver care that is optimal for patients in our population. And I've learned a lot from this, and I definitely have to go back and listen to some of the nuggets. And as you can see, Dr. Remy was talking from a place of experience and not just theory. So I think he's definitely a leader that we should all respect in this field, and also glean from in his experience, and also support him in his business. I know he's building a business too in this space. So definitely reach out to him in that regard. So thank you for listening to this podcast series. I really appreciate, and if you have any questions, please feel free to reach out to us. Thank you. So Dr.